Stephen, we can't hear you.
Platform this morning.
Stephen?
Yeah, you can't hear me.
Yeah, we lost you.
Can you hear me now okay?
Yes.
Okay. So this is the agenda today. We're going to take you overview of the key components of the platform. Just to remind you, it is being recorded. Please keep your microphones muted unless you're called upon to for a question. Use your electronic hand to raise it, and if you have a simple question, please pop it in the chat, and hopefully some of the team might be able to answer that as we go along. So why are we here? So we're here primarily because there's an increasing amount of health data coming in around the hospital in various sources. There's an increasing demand for this data to be analysed and to be made available both within the hospital and outside. And we're also seeing, obviously, that the process around gaining access to that data is complex, bringing together different workflows around information governance, research governance, ethics and legal and so forth to bring all this together. In addition, there's an increasing need for large-scale computing infrastructure to support the analysis that people are looking to do, especially as you start looking at artificial intelligence and machine learning. So we're very aware that none of this is core NHS business, and certainly during the costly sort of and lengthy startup phase, as the product is defined and the service is defined, we wanted to undertake this through a ring-fenced team. So to that end, we're very pleased for the support that Barts charity has given us since for what will essentially then be a 6-year program starting in 2021 and going on through to 2027. And that will include not only us, the provider of the Barts Health data platform, but also in parallel, there's been additional support to establish research groups in Queen Mary, and that together brings together the precision medicine program, of which just one component. So why are we heading down this route? So using the library as a model, the way data has been shared in the past and to some extent currently is by having the model of where you apply to the library or hospital in this case, you specify what data you want, you go through the approval process, and essentially you're given that data to take back to your institution where you then process it by your own means. Obviously, that puts an increasing amount of burden on the user to have the right infrastructure to do that analysis. And it also means that the hospital, the data controller, no longer has control over the data and where it is going to go. So to that end, there's a shift that's emerging and changing across the community, both in healthcare, but also broadly in social care as well, where there's sensitive data, is very much the model of a reading room. A reading room in a library is a very defined space. You, as a provider of the library, you can restrict what users bring into that room. You can restrict what they bring out, and you can also control what data is available in that room. And this reading room model is very much what is one of the components that we've been implementing within the Barts Health Data Platform, as well as both the approval process that goes into that and also the data flow. So the team inside informatics is small. There's 8 of us, but we've also called on colleagues across the hospital to support us in terms of their expertise. And for over the last year, we've been operating with the Data Access Committee, which also includes members of the public on that as well, which we welcome some of those with us today. And for the last 6 months, we've been working with PO Consulting to actually establish some of the technical elements of the platform that we'll give you an overview of today. So technically, we are using the Microsoft Azure public cloud. We have our own dedicated tenancy away from the hospital. Into that, we bring in data from various hospital sources, which we then bring a link, normalize and process, and Ben will tell you a bit more about that. Then once we have a approved project, the secure data environment effectively provides the reading room where the data is placed, and we can supplement that data coming from our records, potentially with external data sources needed for the project, or even specific project-related data. So that we are transparent to what we're doing, we have a data portal that keeps the public informed as to the projects that we're operating, and also helps inform the users and the DAC as to the sort of projects that we have, and help support the project approval flow, so that we end up with a complete record and audit trail of all the interactions that have taken place, so that as we reach our decision. And so what you'll hear today is Rosina talking about the data portal and how we present ourselves to the public, Ben talking about the data flow, and Tony talking about the secure data environment, before I wrap up at the end. So with that, unless there are any immediate questions, I will pass on to Rosina for the next phase of the presentation. Over to you.
Thanks, Stephen. Okay, so I'll just be going through how to use the data portal to request access to data. And supposed to be changing slides. Sorry, it's a little bit slow. Oops, jumped ahead. Okay, so you can use the data portal to request access to Barts Health data, and the types of projects we cover are research projects, service evaluation, clinical audits, and quality improvement projects. Just to emphasize that, just because you're coming to the Data Access Committee or via the data portal to request access, you will still need to go to Jeromo to get approval for research projects, and to the clinical effectiveness units for service evaluation and clinical audits, and to the QI team for QI projects, and they need to be registered in the normal way as you would do. The types of requests we cover are full applications, so which are basically you have all the approvals in place, or you're applying for all the approvals in parallel. And provisional, which is basically you would like to come to the Data Access Committee to get provisional approval for data for grant applications. Okay, sorry. Okay, so then this is the dashboard for requesting access to data. So on this dashboard, when you log in, you'll be able to see a button which allows you to submit a data access request form. You'll be able to see all the draft applications you have started, and all the submitted DARS data access request forms with the overall status. So you'll be able to see whether it's been submitted, if it's in the review process, if the review's been completed or approved. And then at the bottom of the page, you'll be able to see approved DARS as well. And when your DAR's been approved, you'll be able to see a link to the workspace in the SDE. And also you'll have the option to view your application, copy the data access request form so that you don't have to refill some of the information for another application, and also add a link to your publications or reports that you've done following the approval of the project and use of data. So the data portal has lots of capabilities. So it's allowed us to convert the paper form to an electronic version. It will allow you to upload supporting documents like rec approval, CEU registration, your CVs, any training records. It also has a built-in workflow, so you'll be notified of DAR statuses and any actions that different team members need to take, such as the review group will be notified if there's a project for them to review, and when the applicant has responded to the reviews as well. So it allows a two-way process as well between the reviewer, the applicant, as well as the data admin team. Okay, and this basically just summarizes the DAR approval process. I'm not going to go through each of the points, but this is the process that takes and some of the timelines we've been working with. We currently don't have any timelines for the SDE because we're still in the beta testing phase, but hopefully we'll have some established timelines which we can publish on our webpage. Moving on, just touching on what Stephen said earlier about transparency. So the data portal allows us to be transparent to our members of the public whose data we're using for research projects and other projects. And there's a tab on the top where you can click on for public view of projects that have been approved by the DAC, as well as the options to see the publication and the project summary. And yep, this is the end of a basic summary of the data portal. Any questions for now?
Hello, I think I have a question. First of all, many thanks for this presentation. My question is, at which stage we can apply for the data request? Does the proposal needs to be approved first, then we can apply for the grant for the access, or is it like, say, when we are writing the research proposal, then we get access to have a look?
I mean, you can make a provisional application to us when you're writing the proposal to ensure that we have the right sets of data that you require. And if your grant application also requires you to state that you have approval from the Data Access Committee, and it'll also help you to build in the cost for our service.
Okay, so if there's no more questions, Ben, over to you.
Can we just confirm, because Hermant put a comment in, the difference between a full and provisional application was unclear to me.
Yeah, I was going to answer that in the chat, but yeah, we can, as Rosina identified, a provisional one. We're not expecting you to have all of the required approvals in place in terms of EFIC approval or IG approval. You make the application to us, and that makes us aware of what you are planning to do and ensures that those information and research governance teams, as well as ourselves, are aware of the application and can provide any advice that might be needed in terms of what you are planning to do. So there's also a question there around primary care data. The portal doesn't include primary care data by default. You will have to seek that approval directly, but we're very happy to work with the data controller to bring that data into the platform and link it as part of your project. Okay, Ben.
Yeah. Good morning, all. I'm Ben Eaton. I'm the data manager for the research data platform. So obviously part of the platform is having data. The data set that we're providing as the core data set into the research platform is what we're calling the research data extract. This was developed by the Trust Warehouse, and we've since taken it on board and expanded it for use case, which is a wide range of data for specific cohorts of patients. So a cohort-based extract, and it has about 950 data fields. So this covers all the data fields. Covers all the data fields. I won't go over each one in turn. Hopefully it's going to go backwards in a second. But it covers most of the things we'd expect. So encounters, medications, measurements, reports, pathology. It doesn't want to go backwards. As much information as we can on a patient-centric model.
Stephen, can you go back one slide, please? Thanks.
Oh, okay. But this is just basically going over what I said. So you see pathology, inpatient admission details, emergency departments, medicines, measurements, details on power trials, things like aliases, so other MRNs or hospital numbers that patients have. For the extract, we have all the metadata for the extract, so what each table and column means. Now it doesn't want to go to the next table. Yep, there we go. And we have this uploaded to the HDR UK website so that anyone in the public can go and view this information. You can see that we have a platinum metadata score. And if you dig in, you'll be able to see technical details. So each table here has details on the table, and then every single column has details on that column as well. The requirements to use this data is obviously you need the permissions first. You also need a list of identifiers for the cohort or an agreed definition so we can generate the cohort for you. The primary table for each extract is a list of patients that you're looking at. Obviously, you need to get an environment set up for the data to be deposited, and then the ability to actually use the data that they sent you. So as of right now, the data will always arrive in your drive at a CSV format. The way we generate this data is with a Delta Live Tables pipeline, which is visualized here. This allows us to generate multiple tables in the extract simultaneously. So the pipeline will determine the dependencies intelligently, and if a table doesn't have a dependency that's waiting, it will be able to run at the same time as other tables, which allows us to generate the whole thing on a daily basis quite quickly. We also manage the code for generating all the data through GitHub. So this gives us full version control of the pipeline. So any changes we make, we can go back and see what we make, what changes we've made, and it means there's visibility. So any researchers who are using the data can go and look on the GitHub and see exactly how we're generating each bit of data, so they know exactly how it's being calculated. And as I sort of mentioned before, the DLT pipeline is hosted in Azure Cloud, and it uses Apache Spark. So that's the thing which allows it to scale up to use multiple computers at the same time to generate multiple tables at the same time quite quickly. This touches on the metadata that I talked about before, but you can see, again, in the actual system, we have comments on every single data field, and we also have information governance coding. So we code both the risk and severity of each field against information governance criteria, the risk being how likely it is that there could be identifiable information in there, and the severity is if there was identifiable information in there, how bad would it be? So you can see for like the allergy ID, this is 00, it's an internal number. There's no reason why it could ever be sort of identifiable. Person ID, slightly more severe because if you had access to the backend system, you could actually get access, and then an NHS number is like quite high risk and severity. And this means that for any given extract, we can filter out any columns that don't meet the IG rating that the DAC has approved. Once your extract has been generated for a given project, we load it into your environment using Azure Data Factory pipeline. All the pipelines are also version controlled through GitHub. These aren't written in code, so the pipeline details are stored in what's called JSON, but it's just a markup language to store all the details for a given extract. These pipelines can then be configured to be single use, refresh on demand, or perform our regular data import. So we could set it up so that every day you get new data for your particular cohort of patients. And it will show up as a CSV file in a folder on your desktop in the research environment. I think that's it. Yep. Any questions?
So Mohammed, you've had your hand up.
Yes, thank you. I'm a patient in many hospital settings in Essex, in Central London, and in East London. So I have different hospital records. UCLH gives me something, Barts gives me something, Queens and Kings in Essex gives me some different reference number. And I'm wondering, is there a way that data can be harmonized for the patient like me? Because you then have the centralized NHS record system in terms of all the data management. So will there be a risk of duplication or will there be a risk of standardization? How do you address that? Thank you.
Yeah, so if you have data, like we obviously only have access to the data that's in the Barts Trust. If those data are stored elsewhere, then it's a sort of complicated process of you have to also apply to that data controller for the project, and then we in that data controller have to sort of get together and figure out how to do it. It is like very technically possible to like link the data. It's just more complicated, if that makes sense.
Next up, Rui.
Oh, hello. I'm a cardiology consultant at Barts and also involved in informatics. So I've got a question. When you speak about data, what type of data are we speaking about? Is it for clinical data? Is it just going to be SNOMED codes and OPCS4 codes of what's already available inserted into the system? Do you have any information on the data that's available in clinical letters, ECG reports, or that's for a subsequent phase in the project?
So primarily, yes, it's the data from the EPR, and like what the data set that we have right now doesn't include much complex mapping. So it's more or less what comes out of the electronic patient record is what's in the data set. We do have reports and clinic letters to a reasonable degree of detail. A lot of those are stored in the EPR as sort of binary files. So all of those we have, like hundreds of millions of letters and reports. There are some that we don't have, because they're stored in basically different systems that are more difficult to access, and that's part of like the longer term part of the project. So there's a question in the chat about imaging data. So that's part of something that we're working on right now, which is we have licensed a tool from Sectra called Export and Anonymize. That's in test right now, so we're currently testing it, and hopefully, fingers crossed, within about a month or so, we will be able to then use that tool. The way that would work is you would generally provide us with either a list of session numbers if you have it, or the criteria for what kind of images you want. We will run an extract, and then we will move those image files into your secure data space in the same way that we move the CSVs. Question about the bioresource. So the bioresource uses the research extract. So they combine the data that we give them from this extract with their own biosamples data to produce that sort of combined data set and samples service.
All right, thank you, everyone. Thanks, Ben. And now, hopefully, Tony has control of the presentation.
Okay, so I'm going to talk about the secure data environment itself. If I can figure out how to drive it forwards. Okay, so the secure data environment, we mentioned that already, but what actually is it? You can see an architecture diagram on the right, which I'm not going to go into in detail, but basically it's a set of core services protected by a firewall. And on the right, you'll see individual workspaces where the projects happen, where the project computing happens. So each project will have its own computing resources deployed per project in a secure environment. The user access is tightly controlled. Only authorized users have allowed access to the platform, and people will only see what they're authorized to see. So a person who has access to workspace 1 on the right there, for instance, will not have access to workspace 2 or 3 or 4. It's all tightly controlled. Network access is via MFA login, secure login. So you need to have an account on the Azure portal from that. And once you have that account and the secure login, you can then access the portal through through your web-based browser. Within the SDE, when you have access to your computing resources, you do not have general access to the internet outside of that. So you can't arbitrarily pull in things. Things are tightly controlled through the airlock mechanism, making sure that nothing gets into or out of your workspace without approval. So within the SDE, there's a hierarchy of resources and roles which pretty much match each other. At the top level, you have the SDE admin who creates workspaces and assigns people to workspaces with roles in the workspace, one workspace per project. Within the project, within the workspace, you have a workspace admin, and this person will typically be someone like the PI or the computing expert on the project. They create workspace level resources which are shared amongst all the users of the workspace. An example might be Gitea, a Git clone, allowing people to share their code internally in the workspace. Also in the project, you'll have workspace researchers who have a slightly lower level of access. They can't create shared resources, but they can create resources which they themselves use individually, their own compute resources, their own machine learning resources. So workspace researchers will not have access to other workspace researchers' resources, but the workspace admin will have access to all of them. Finally, across the board, there's a role of the airlock manager. So the airlock manager is Ben or Evan, somebody in the data team, who ensures all data movement into and out of the workspace is appropriate and aligned with the data access request that was made for this project. Your data will be scrutinized to make sure that it's appropriate. And I'll come to that a bit more later. So this is the typical view of a landing page on the SDE. You'll see it's actually called the Azure Tray up here, but for our purposes, Tray, a trusted research environment, and SDE, secure data environment, they're close enough to equivalent that we can ignore the difference. Consider them synonymous for today. So within this tray, within this SDE, we have three workspaces. T1, my testing workspace. We have a workspace for the airlock mechanism itself, which nobody goes into directly. Oops, skipped ahead. Why isn't that coming back? What's going on? Okay, so three workspaces. I think there's a lag on this. Excuse me for this bit. Let's get back to that slide. Okay, three workspaces here. My test workspace, my playground, one that we've already set up for our first people set loose on the beta. The SDE admin will see all project workspaces, the workspaces of every project on the SDE. The workspace admin or researcher will only see the project workspaces they've been given access to. So when the person who submitted this request comes to look at the SDE, they will only see that tile for their one workspace. If I click into a workspace, my own test workspace, for example, I can see at the top I have some buttons for controlling it. I can update the workspace if the template for the workspace changes. I can disable it, which is one way of putting it temporarily into cold storage, which helps to reduce costs. And ultimately, I can delete it as well. I have a set of tabs which give me information about the overview of it, details, history of operations, and an actual operations log. And then below this, I have tiles for each of the workspace services. So I've created a virtual desktop service, which allows me to log into computers using the browser as my desktop. I've created a MySQL service for this workspace, which means that I now have access to a full MySQL database, which is again protected from any other access outside this project. And I've also created an Azure machine learning workspace, where I can run my machine learning models and use the Azure machine learning platform and process my data in that way. I can create new services by going to the Create New button here, and there are a variety of other services that I can create. Let's go on and look at that. Sorry about the lag time. I don't know why it's taking so long. Okay, so here we go, overshoot. So if I were to click on that Create New button, I would then see this menu here. So the workspace services are self-service. The team that have access to the workspace can create the resources that they need for their project, tailored to what they want. At the moment, we have these 5 services which we're enabling. Guacamole, which is a virtual desktop service. Gitea, which is a Git clone, Git platform for allowing you to manage your code. Full-featured DevOps platform. Azure Machine Learning, and then 2 types of SQL database, MySQL and Azure Native SQL. Other services are available, but we haven't yet tested them thoroughly, so we don't yet know how to support them. And because these are all following a template format created in Terraform, for those of you that know that, it's possible to create new services on the fly relatively easily and add them to the SDE as we go ahead. So we can create new services to enhance the functionality should that be needed. If I drill down further into the virtual desktop service, for example, you'll see the presentation looks very similar. The layout is the same, but within this, I now have my user level resources. I have a Linux virtual machine, which I have created, and I have a Windows virtual machine, which I have created. For each operating system, you have a choice of operating system editions. So for Ubuntu, we have the 2 latest versions, 22.04 and 24.04. For Windows, you have access to Windows 10, 11, and 2019 data service editions. These virtual machine images are being customized by us to contain the software stack that is appropriate for the research that happens here. So there was a question about that in the chat earlier. Basically, we can customize the software that's installed on the virtual machine image to make sure that you can do all the work you need to. If you still need to bring in further software, you can do that. We have a proxy service which allows you to download software from Python platforms, R, Ubuntu updates, things like that. So the standard repository servers for standard repository packages, you can pull them in. You get to choose the size of the virtual machine that you want, how many CPUs and how much memory. The smallest you can choose is 2 CPUs and 8 gigabytes of RAM. The largest you can choose at the moment is 36 CPUs, 880 gigabyte of RAM, and a GPU. And that one costs £100 a day. So be careful of that if you've got a tight project budget. So I've mentioned the virtual desktop environment. This is what it looks like. These are 2 screenshots of it running in my web browser. So you log into the virtual desktop environment, essentially using 2-factor authentication, and then you can create a browser-based version of your virtual desktop for either Linux on the left or Windows on the right. And again, they have the same levels of customization: R, iStudio, Python, Conda, Visual Studio, all sorts of other tools. And we are moving towards making sure that you have exactly the same versions of each piece of software on each machine as well. So if you need a specific version of R on Windows and then you suddenly need to use it on Linux, you'll get the same version. Data can be shared between the virtual machines by a shared storage service. So each project will come with an amount of shared storage, which is visible to every virtual machine that you boot. So if you save a file on the Linux platform to the shared storage, it'll be visible on the Windows machine immediately. So let's move on to the airlock mechanism. So there's a state diagram on the right, which I won't go through, but basically the airlock mechanism, as its name implies, is what makes the environment a secure data environment. There's essentially 3 steps to it. You put data into the airlock, you request that it be reviewed. If it's approved, you then pull data out of the airlock. And it's the same process in either direction. If you push the data in from outside the SDE, it gets reviewed and then you can download it into the SDE. Or if you want to export, it goes the other way around. So essentially you create an import request and then a secure location is created in the cloud. And this is accessible only from outside the workspace for an import request. You then upload the data and submit the request. Once you submit the request, you can no longer change that data. You no longer have access to it. So we know that there's no possibility of you making a request and then changing it after the decision's been made. Data is scanned for malware, and then a request is sent to one of the airlock managers asking them to review this data. The airlock manager logs into the SDE and spins up a virtual machine inside the SDE platform. So they have the same secure level of access to this data. They don't have to download it to their local platform. They don't have access to it over the open internet. The data is still securely held within the SDE. The VM is created automatically, data is put on the disk, and the airlock manager can inspect the data and make sure that it's appropriate. The research team do not have access to that virtual machine, so they can't sneak access to it while the airlock manager is doing their job. Once the data is verified and approved, it's moved to a new secure location from where the researcher can log into the virtual machine and then pull the data down inside their SDE. So it sounds like a complex process, but it's actually quite easy when you get the hang of it. And this is the crux of what makes it secure, in that data can only flow in the right direction, and only what goes in and what goes out comes out is only what is supposed to go in and out. So summarize that, we have deployed a beta of this secure data environment. It gives secure data to access in a controlled environment. People can access only what they should be able to access, and people can control exactly the resources that are deployed in their environments. So if you need a GPU for an hour, you can use a GPU for an hour, and then you can shut it down. You're not paying for it longer than that. Data is not shared between environments. If I, as a researcher, have access to 2 different workspaces, I cannot copy the data from one of those workspaces to the other. The only way in or out is through the airlock, and we would spot that. There's no external access to data. The functionality of the SDE can be enhanced and updated on the fly. It's all template driven for all of the services, from the tray itself down to the workspace templates and the resource templates. So we can enhance the functionality in those on the fly. We can add new services on the fly. Next up, what we're going to do now that the beta is out there, we need to improve the scalability, robustness, operational aspects so that we can handle large numbers of projects. And there are more services available. We need to test them, make sure that they're usable and correctly documented, and basically unleash the platform for more users. And with that, any questions?
So, Tony, I think there's one question about will users be able to download our libraries directly?
Yes. So one of the shared services is it's basically a proxy server which allows you access to limited parts of the internet, which means you can get access to R libraries, CRAN, CPAN, Python, all of the various standard software packages, and then you can download those into your platform. If you find that there are packages, if we find that there are packages which are needed across the board by many people, we will simply customize the images further and put those on there directly. So then there's a question about, you have to choose a program that is cost effective. And what about the efficiency and quality of work as well to achieve the common goal? Is that one of my questions, or is that from someone else? I'm not sure that applies to mine.
I don't think it's a technical question necessarily,
Yeah.
Tony. I think there's probably a bit of explanation that the applications, when they come through, will be expected to outline what tools they're planning to use, what coding language they're planning to use,
Mhm.
and the group should know that will help formulate costing. So I think there are a lot of questions about, will R be standard, will Python, will SQL? So that we're not dictating what the applicants have to use as the tools to analyze the data or to structure queries around the data. So I hope that that is clear. That will need to be exposed in the application as the applicant describes what their intents are. And we would then advise as part of the approval process, the costs and whether or not there's any part of the technical specification which we're not able to provide in this environment. However, there will be default standard tools. And then if you want to bring something that's more bespoke and or niche as part of your project, we would look at that and advise. The platform is web-based, and obviously it's in a cloud environment. And so it's quite flexible in what you bring to the table. It just might mean that there's an incremental cost in order to host that for you. Can we just go through some of the, I think Byoku's helping in the background answer some questions. Angel, if we just start at the top, your question around data quality, data is as good as the user's putting it in. Researchers and people that request access to data, I think, are very used to having to do their own data quality checks before they use the source data as part of their metrics. And I think we answered the question about SQL. And I think we're then on to, there's a hand. Is it Sobia?
I just had a question because I've used something similar in another hospital for another data platform, which was Epic. So we had access to the back end of the database. We pulled the data that we needed, and if there was something missing, we could then go back and adjust the SQL query to then pull further data. I wasn't quite clear from our request how much information is on that initial CSV that we're provided, and whether there's something else that we can then adjust what things we actually need from that quite large CSV.
Sorry, Sophie, it's probably my fault, Stephen, because earlier I tried to answer that question. Each of the applications will describe what data they're applying for. We're not providing the entire patient index to any one project. It will be a cut down extract based on the parameters that is being applied for. It might be that someone has justification for saying we want the entire patient index for everything that exists. I highly doubt though that there would ever be a case where that happens.
And if there is something that isn't in the research data extract, as Ben described in the the HDR UK metadata, then we can look to see if that is how that can be extracted from the records and brought into that research data extract. And that's again, what as Sarah said, why we ask for your requirements to be specified at the application stage.
I think that we have a very ambitious program across the trust as well to digitize more and more patient data. So for example, we've just gone live with anesthesia records. We've just gone live with the critical care clinical record, which was all on paper charts. And so the research data extract will constantly be updated as more patient care on the hospital side gets added to the digital record. It's not, I don't want anyone to think that it's just static and what Ben has listed is now for the forever point in time. As we add new things, we'll be adding histopathology slides. When that goes live, hopefully that will become part of the imaging data as well. And so as we mature digitally in the hospital with more systems, those will be added to the research data set.
Thank you.
So I'll just answer two other questions that come in the chat and then move on to the final wrap up where there's time for some more questions. So Carol asked, what is the service standard for time in the airlock for data input and results output? What criteria are your staff using to approve? A lot of that would depend on the individual request. Some of those quests might be relatively straightforward in terms of bringing in additional software in, which is the second question. Or if we're exporting data, then we'll need to be looking at what was in the original request and how do we provide and maintain their patient privacy and so forth around that. And Tony's answered the second question, so I will then move on to the final few slides. So where we are at the moment is the SDE is available. The data portal is still coming to the end of its internal testing. We hope that will be available this week, and we'll send an email out to this list when that is all ready. As Ben mentioned, PAX is due sometime towards the end of this year. It might be as early as the end of October. It might be into November. We're sort of in the hands of the Sectra and PAX to deliver and migrate that into the production instance. And our thanks to the Barts bioresource that's supporting the licensing and infrastructure costs for that in the initial phase. Once we have that data in, we are still planning a real launch of the minimal viable product, which we see when we have the imaging data, and hope to get some user presentations to complement the sort of the feature presentation that we've been doing today. So the important question is, how much does it cost? So there are some administrative charges around supporting the application request, and also then in terms of the infrastructure and the verification needs to go around each of the users. The key important thing is that line at the bottom. If there are costs coming in through the data analysis work that you are doing, the expectation is that you will have funding to support those costs, as well as the more fixed and predictable administrative costs. Barts Charity has generously provided some support to kick off activities, but that obviously is not a remit that they are looking to want to continue to do forever in the future. So the goal is very much to migrate to where projects can be self-supporting, but we're very much happy to have a discussion about that over the review around that. So coming up in the pipeline, there's more enhancements around the data portal coming. The data core, we're looking to include OMOP structured data sets and see about how we can integrate natural language processing of some of those reports that were mentioned as sort of blobs, so that we can extract out that metadata so it's available and more searchable as part of the record of the patient record. And there's some additional features in the TRE that have been provided by Microsoft and the community, but which we've not tested yet. So we're very happy to work with people who would be interested in trying out some of these environments, so that we can bring those into the main service catalog for everyone to use. And so I think with that, thank you. There's some contact points and the web URL. And then just to say, are there any more questions for the team? So there's a question around, do you benchmark your adopted systems to improve or develop work? So the Azure environment has got a very large variety of virtual machines, storage, different processors and different tools. We're very happy to work with you if you have specific needs to try and make those available, so you can explore the different options that are available to work out what might work well for your application. But our experience is that every application has got different computing and storage patterns, And so each project may have to do a little bit of experimentation themselves to work out what the best solution is for them. We're very happy to provide advice, but it's going to be very much project dependent.
Xavier is asking
Yeah.
for a price sheet. The answer is yes, we can give you some approximate costs. We have a custom price list just for you, Xavier.
And if you if you Google Azure pricing scheme, Azure pricing cost calculator, you will get an admittedly simple but expansive list of all the different resources that you can potentially use and with costs associated with them.
How do I factor in my discount for that though, Stephen?
Sorry, I don't understand the word discount.
It's no joking matter though. Stephen did make it clear at the beginning. This is outside of our core NHS business. The charity has been extremely generous in getting us to this point, and we do need to find a way to self-sustain. And so we will be looking at that as part of how we give access and how we create a model around this, because it would be a shame if we had to give it up as a SIP because we couldn't find a way to prove that it was paying for itself, washing its face, I think the phrase is.
And certainly if you have something very interesting, that might be worth approaching Microsoft that provides grants for cloud use in areas that they're particularly interested in promoting. Charles.
You're on mute, Charles.
Okay. Angel?
Charles?
Can you hear me now?
Charles. Yeah.
Yes.
So I think this is just an opportunity for me to make a couple of points. First of all, to thank the team that you've heard from this morning for really fantastic work over a 2 to 3 year period. Building up and building up and building up. Secondly, I'd say that we now do have substantial experience of doing data access requests through the committee that we've set up. And that now works well. I think we turn around applications at speed. People don't have to wait. And obviously the next test is the test of whether we can actually show you where the data and how to use the data works. I would make one offer around that. When I look at the list of people who've attended today, it's a mixture, I think, of clinicians, researchers, data scientists, and so on. There's probably less clinicians than I might have hoped and so on. But I think there is a challenge which I have made all the way through this. I've made it to Xavier, I've made it to Hemant and others, which is trying to address that question that Angel put about data quality. In the end, the data quality is about doctors and nurses using the electronic health record to the max. In other words, recording structured data on a regular basis for everything that you do and see and say with and for your patients. And I think the message for the scientists here is you have to collaborate with clinicians to make a project work, and be brutal with your clinicians. Say it won't do just to write a bit of free text and hope for the best. It has got to be structured data every time you see a patient. Add something. And then the last bit, which you'll all laugh at because I know that you love me talking about it, but we do now have significant experience in our life sciences team for using SNOMED resources. SNOMED is an amazing ontology for doing clinical analytics. And the more SNOMED that goes into the record, the better we'll do. So if you don't know what I'm talking around that, do come and talk to me about how we can use SNOMED better across the trust. So use the record, use the ontologies that come with the record, and explore the resources that have been shown to you today. And we'll all be fine. And we'll give Griffin a bit of money as well.
Angel.
Oh, yeah, can you hear me?
Yeah.
Yeah, just have a question of, because I know Sarah mentioned about, being able to sustain ourselves, and we have this really great data platform that we're working on. I'm just wondering, because I did work previously in clinical research and companies, and how on our end, for example, is it can we kind of like how to promote this to this research, like help research companies wherein I guess the challenge on that side is for them that they're having a very hard time to get patients with very specialized medical conditions. And I think this is quite an opportunity for, if we can promote, for me, I can promote it to those companies to have a platform that they can use.
Yeah, so we've had some discussions as to how we might sort of reach out to the more commercial uptake of some of the data sets, and certainly seeing if we can extract data around specific conditions that would then allow us to target pharmaceuticals that are interested in those conditions and other strategies like that. So that is certainly something that we've been discussing internally as we enter into our growth phase. Sarah?
Mine is not a question, Stephen. I just wanted to really, really emphasize what Charles said about this team and the talent and the knowledge that we have. I really, really want to thank Ali and Victoria, who are here from the charity. I know a lot of people have dropped off, but we've had really good support over the years in, kind of when we were doing this, I wouldn't say amateur, but in a less sophisticated way. John Prowl has come, Claude, Carol, lots of people who have really just stood by with their support, even though it wasn't as smooth as it could have been historically. And still persisting, Xavier's here, who has been helping with OMOP, and certainly Dan and Melly, who's been doing so much work around the EPR system and all the data we've been slowly adding to it. I'm sure I've left people out, but I just want to take a moment and reflect a microsecond. This team have really, really worked together. There were times where we thought we were just not going to get to this point, but actually, I hope that the charity sees that this is one program which is really, really coming along strength after strength. And it's so exciting. I'm so excited. It's such a great highlight of my day outside of the NHS work, which is very challenging right now, to see something that is such a good news story. So, Stephen, thank you so much to you and the whole team for all your hard work on this.
Thank you, and as you say, the credit goes to the team as well. So I think we're at a final question from Reshma.
Yeah. I wanted to thank Dr. Guttridge for the very astute and wise remark that he made, and which actually, if you look at it and reflect on it, underpins the success of this entire program, which is when you deal with a patient, write copiously in the notes. Because if you don't have those, we can't build anything. And that, I think, is the key to everything. So, Dr. Guttridge, thank you.
Everyone say thank you to Charles, his lifetime achievement.
So thank you very much. Coming, we're a few minutes over.
Sorry,
the
Stephen.
top.
Stephen, there's one question in the chat we haven't addressed.
Oh, sorry.
About fees for QI projects and audits.
Yes, so I think certainly for the April process, I don't think we're seeing at the moment scope of making charges. But if you were to make use of the cloud environment, then and we might just think about some charges around the extraction of the data, then I think we really need to look to cover our costs. Our main principle with internal work is, are we covering our costs? Anything else? Any other questions that missed in the chat?
No, that's it, I think, Stephen.
Okay, lovely. Well, thank you very much to the team. Thank you very much, everyone, for attending. Our contact details are on the page. Please get in touch with us if there's anything else that we can help you with, or anything at all. Thank you, everyone. Have a good day. Bye.
Bye. Thank you.
Bye. Thank you.
Bye. Thank you.